In this session, I'm going to go through a very brief overview into dementia. We'll talk about the main causes and the signs and symptoms of dementia before going through the pathogenesis and management of the most common cause of dementia, which is Alzheimer's disease. Now, before we do that, we'll just go into a very brief overview into the role of the neurotransmitters within the CNS. And as we already know, neurotransmitters, they produce excitatory or inhibitory responses in postsynaptic neurons. The neurotransmitters themselves, they're chemical messengers that are released upon stimulation because of an action potential coming to the presynaptic neuron. It releases that neurotransmitter into the synaptic cleft, and it goes on to bind a receptor, where it can be excitatory or inhibitory, of course. That neurotransmitter can then be degraded, it can diffuse away, it can be reuptaken and reused. There are various things that can happen to it. And there are lots of neurotransmitters within the CNS itself. For example, glutamate. So glutamate is mainly stimulatory, and it's involved in learning and memory. We've got the monoamines such as serotonin and dopamine and noradrenaline. Noradrenaline, as we know, functions at adrenergic receptors as part of the fight or flight response. It's therefore involved in arousal, mood, and blood pressure. But you have changed levels in disorders such as depression and bipolar. Then you've got serotonin. Well, serotonin is involved in sleep and wakefulness, mood, feeding, and appetite. And it's involved in diseases such as depression and eating disorders. And then you've got dopamine. They function obviously at dopaminergic receptors. It's involved in motor control, motor and reward pathways, and it's involved in diseases such as addiction and the rewards pathways. And acetylcholine, this acts on the cholinergic receptors, and those are your nicotinic and your muscarinic receptors, and they're involved in multiple pathways, so part of the autonomic nervous system, but also in arousal, cognition, learning, memory, consciousness, motor control, all manner of things. But there are decreased levels of acetylcholine in Alzheimer's disease. So as we've already said, dopamine, noradrenaline, and serotonin are involved in mood and anxiety. And so if we're thinking about serotonin, what it's involved in, it's involved, like we've talked about, in mood, appetite, sleep-wake cycle, and it's involved in diseases such as depression and eating disorders. And it's decreased in depression and increased in autism, for example. We've then got noradrenaline. So noradrenaline, again, it's involved in arousal, sleeping, mood, emotions, learning, and memory. It's functioning at those adrenergic receptors, remember. And of course, the disorders include depression and bipolar, as we've already talked about. And the levels are decreased in these cases. And then finally, we've got dopamine. And this is all to do with, they function at dopaminergic receptors involved in motor control, emotion, reward pathways, and they're involved in diseases like we've talked about, such as addiction. And dopamine levels are increased in addiction, for example, in that reward system pathways. And as we already know, acetylcholine, and this is the one we're going to really focus on when we come to Alzheimer's, that's decreased in Alzheimer's. So when we're thinking just quickly, briefly on these three, because they are important to understand, they're involved in anxiety and mood. So if you're looking at noradrenaline and serotonin, so you can see that's primarily thinking about anxiety. And then when we're thinking about mood as a whole, we're thinking about all of them. So dopamine, noradrenaline, and serotonin. So there's an awful lot of overlap in the function of these neurotransmitters. But really the focus of today is all about dementia. So this is what we're going to talk about now. And remember, it's only a very brief overview. You'll learn a lot more about dementia by going into more detail and talking to clinicians and getting that kind of information from them, because I don't have that clinical background to give you. So when we're thinking, what is dementia? Well, this is where you get the development of memory impairment and impairment of other cognitive functions with the preservation of a normal level of consciousness. It's irreversible, it's progressive, and there are loss of those higher mental functions of thinking, of your memory, and the ability to perform everyday tasks. And over time, they require more and more help to perform those everyday tasks. It's not a normal part of aging, and it's important to understand that. And it's a collection of symptoms, not a specific disease. So dementia is all of these symptoms locked in together, if you like. And that's when you have some of those symptoms and they meet the various criteria, then you will have, or your family or whoever it might, your patients will have dementia. And so dementia diagnosis, it requires defects in a variety of different systems, if you like, or higher order skills. So you need defects in possibly memory or your language skills or understanding information, spatial skills and spatial awareness and judgment and attention, for example. And many people will have problems controlling their emotions, and people it's often associated with the difficulty solving problems. You're losing those higher order thinking skills. People may have personality changes. They're quite common as well. And dementia is becoming a major health problem in the developed world. So dementia will become what is thought one of the major chronic health conditions of the 21st century. So if we're looking at Australian numbers as they currently stand, in 2014, there are about 330,000 Australians with dementia. And it's predicted, and that's out of about 50 million people with dementia worldwide. And it's predicted by 2050, there'll be around about 900,000 Australians with dementia. So just under a million. That's a huge proportion of the population. It's somewhere around about 1.5% of the population of Australia will have dementia at these various time points. And worldwide, it's predicted by 2050 to rise to about 130 million. So it is very significant. So what about dementia and Alzheimer's disease? Are they the same? Are they different? Well, they're often used interchangeably. So people will say, oh, they've got Alzheimer's or they've got dementia, and they'll use them interchangeably, but they aren't actually the same thing. Like I said, dementia refers to a group of symptoms that affect memory and reasoning and other higher order thinking skills. And Alzheimer's disease is the most common cause of dementia, with vascular dementia, for example, related to stroke, being the second most common cause. And so Alzheimer's makes up around about 60 to 70% of the causes of dementia, and vascular causes, such as related to stroke, make up 20 to 30% of the causes of dementia. And remember, of course, that Alzheimer's makes up around about 1%, about 1% of the Australian population, with dementia as a whole being around about 1.5%. We also have other causes. So there are other causes include things like space-occupying lesions, so cancers, for example, infectious diseases leading to encephalitis, and trauma, for example, due to head injury. So there are other causes of dementia. So with Alzheimer's, there's an impairment of higher intellectual function with alterations in mood and behavior. And it progresses over time to disorientation, memory loss, and language issues. And people over time can become disabled, immobile, and mute because of it. It predominantly, like we talked about, affects the cholinergic neurons, but the cholinergic neurons present within the hippocampus, within the limbic system, one part of which is the amygdala, and the prefrontal cortex. So that's where you have your higher order thinking, but it's also where we have a lot of our long-term memories. And as we know, acetylcholine binds to the cholinergic receptor, so this is just a bit of a repetition for you. And its roles are involved in arousal, cognition, learning, memory, consciousness, motor control, emotions. And you can imagine now that if it's got all of these roles, when we start to have reduced levels of acetylcholine, these roles start to become less significant or less enhanced, if you want to think of it like that. So when we're thinking about issues with the prefrontal cortex, we're thinking about problem-solving issues, planning issues, behavior issues, emotional issues. And with the hippocampus and amygdala, we're thinking about memory issues. So you can start to see how these start to all tie in together. So we've just got a quick question for you. It's really quite a basic question, and it's really a series of true or falses for you. So I'd like you to read this, press pause, and then we'll quickly go through the answers. So which of the following are correct regarding dementia and Alzheimer's disease? Dementia is the most common cause of Alzheimer's disease. That's obviously incorrect, because Alzheimer's is the most common cause of dementia. It makes up about 60 to 70% of all cases of dementia. Dementia leads to short and long-term memory loss and decreased higher-order thinking skills. That's obviously correct. Alzheimer's disease affects cholinergic neurons, which use acetylcholine as their hormone. Clearly incorrect, because acetylcholine is not a hormone. What a ridiculous question, but I'll put it in nonetheless. Acetylcholine and their receptors influence brain regions involved in memory, understanding, learning, motor control, arousal, and consciousness. Clearly correct as well. So in the second part of this, we're going to look at an overview, and it is very much an overview of the pathogenesis of Alzheimer's, and then touch on the management of Alzheimer's, remembering, of course, that I am not clinically trained to look after this or anything else for that matter. So really it's clinicians who would be dealing with the management of Alzheimer's disease. So to get the most up-to-date information, you should obviously talk to them. But this just gives you a kind of overview of some of the principles of it. So as we know, acetylcholine acts on our cholinergic receptors, where it's critical for memory and cognitive function. There is just a simple image showing the same thing. Acetylcholine crossing the synapse, binding the postsynaptic neuron and stimulating it. And that acetylcholine is obviously broken down by acetylcholinesterase, and the choline the choline goes back into is taken back up into the presynaptic cell, where it can be recycled to form more acetylcholine. And in Alzheimer's disease, the levels of acetylcholine are reduced, and that leads to some of the symptoms, so memory loss, personality, behavior changes, reduced arousal and cognition, as we've already talked about. But two of the earliest signs, of course, are memory loss and the ability to learn. And those are two, like I said, two of the earliest changes that are seen. And so what about the pathogenesis? What's going on to cause this memory loss? What's going on to reduce all this acetylcholine? What's basically happening to stop these neurons from functioning correctly and then actually going on to die? Well, you seem to have the buildup of beta-amyloid protein plaques. They build up outside the neurons, and neurofibrillary tangles accumulate inside the neurons within the brain. And here's a nice little image just to show what it looks like. Yeah, here you've got your normal neurons, and obviously remember that they can be talking to up to 15,000 other neurons. There's huge amounts of communication going on. And here you've got your amyloid plaques, which are outside the neurons, and you've got your neurofibrillary tangles, which are within the neurons themselves. So what has happened? There are lots of risk factors, and we talked about some of those. The most important one, obviously, is being age, but other risk factors are there. So hypertension, cholesterol, smoking, stroke, if we're thinking about the vascular causes. And that seems to lead to altered processing of the amyloid precursor protein, or APP. Now, you can go and look into the mechanisms behind this in more detail if you want to. That's up to you. But I think the key factor is these are all risk factors to lead to altered processing of an amyloid precursor protein. And this protein, APP, it's found in the membranes of nerve cells. And it's converted to this beta-amyloid instead of its normal product. So there's altered processing going on. This beta-amyloid protein starts to build up and clumps start to go on to form plaques. Now, beta-amyloid is also seen in normal aging, but not at such high levels. So what we're seeing much bigger levels of beta-amyloid forming these plaques, which is toxic at the synapses, and that leads to neuroinflammation. So now we know we've got these amyloid plaques that are building up, and these are causing damage around, toxic at the synapses, which are all over the place, remember, and that starts to lead to neuroinflammation. And so basically by doing this, the plaques that are building up are stopping the neurons from effectively communicating. That leads to neuron dysfunction and eventually neuronal death, and therefore the loss of cholinergic neurons, and that, of course, as the neurons die, will start to lead to cortical atrophy, as the cerebral cortex starts to die because the neurons are dying. But that neuroinflammation in itself also leads to the accumulation of an abnormal tau protein within the cells. These neurofibrillary tangles begin to form. And when the tangles are starting to build up, nutrients and other essential molecules can't be moved throughout the cell as efficiently, and that means these cells will also die. So these two things are really working together hand in hand to eventually lead to neuronal cell death and therefore cortical atrophy. And if we're looking at the time scale to this, and remember that pathogenic pathway that I was showing you really is a very, very simple, version of what's happening on. There are huge numbers of mechanisms proposed and known, or theoretically known, going on. But it seems that what's happening is that the beta-amyloid plaque accumulation occurs before clinical Alzheimer's onset and before, therefore, significant cognitive impairment. So if you're just taking a little look at this diagram, you can see that the beta-amyloid formation, this is coming on much earlier, and your cognitive performance is absolutely fine for the early stages of this. But then as you get these beta plaques forming more and more, as we've already talked about, you start to get inflammation at the nerve cells. And as this is happening, you can see we're now starting to accumulate the tau protein, and we're starting to lose some early cognitive performance. And as the tau protein is forming and we're getting more beta amyloid and we're getting more inflammation, we start to get more synaptic and neuronal cell death and loss. And of course, after this, you could then be saying you're starting to see the cortical atrophy as well. So in this early phases, you can see this is your preclinical asymptomatic Alzheimer's and your mild cognitive impairment, because really the cognitive performance is pretty much near normal at this stage. You're only mildly impaired. And then as it gets more severe, you can see that you're hitting clinical Alzheimer's disease with significant cognitive impairment. So as we've said, the plaque and tangle formation, they lead to neuroinflammation, the loss of cholinergic neurons, and cortical atrophy. And what happens as you're getting that atrophy, you start to get shrinkage of the hippocampus, and therefore that leads to memory loss and behavior changes. Therefore you're thinking that memory, because hippocampus is involved in memory formation, involved in memory, so therefore you're starting the memory as being affected first. But then you can also get impairment of the language areas and atrophy of the language areas. So you can see this in an Alzheimer's brain, and you can see this in a healthy brain, and you can see you're getting significant atrophy, as well as the atrophy involved in memory, which we've talked about already. But also with language areas, so that can lead to reduced comprehension, and it can also lead to confusion. So the other thing that you can also see in this image is you can see that the ventricles are also growing larger. And remember, this is where your CSF is. And imaging can often detect this enlarged ventricle, which can suggest Alzheimer's as a possible diagnosis. And so as we get shrinkage of the cerebral cortex, we're obviously getting reduced cognition, personality and behavior changes, emotional outbursts, and language impairment, as we've already talked about. So Alzheimer's disease itself is irreversible and it's progressive, and it's put into a variety of stages. So you have mild cognitive impairments, and this is where we're mainly affecting the hippocampus in the temporal lobe, and you're getting short-term memory loss and declined attention span. And families will often just put this down to natural aging. You've then got mild Alzheimer's, where it's spreading to the parietal lobe, which you can see up here. So there's a nice little image to help you there. And so people may get poor directional sense and object recognition, again to do with memory, language difficulty, and apraxia. So some movements may become hard because there are spatial awareness issues arising in the parietal lobe within the somatosensory cortex and other associated regions. And then you get moderate Alzheimer's, where we're getting spreading to the frontal lobe. And at this point, people might require some home help because there's long-term memory loss. There's an inability to recognize close relatives, emotional changes, but also aimless wandering and incontinence, hence requiring some home help. And then finally, we go into severe Alzheimer's, and this is where it's spreading throughout the frontal lobe and the cerebral cortex, and all the way back to the occipital lobe, which is obviously involved in vision. And so then patients at this stage, they're reliant on others for even the most basic activities, because you've got a complete deterioration, loss of bodily functions, visual issues, severe exhaustion. They're often bedridden, and obviously this is the point where it can eventually lead to death. So diagnosis, obviously it's clinicians who are going to do this and go through this in a lot more detail with you, but past medical history can help to identify past medical problems, for example. So in a dementia workup, some of the things that may be done They'll do a neurological exam and a physical exam. So they'll include evaluations of hearing and sight, heart and lungs, as well as temperature, blood pressure, pulse readings. They'll be doing some various neurological bedside screening. They'll also do a neuropsychological evaluation. So doctors will use a variety of tools to assess memory, problem solving, attention, vision, motor coordination, and abstract thinking, such as performing simple calculations in your head, for example. So it's thinking about those problem solving and memory side of stuff. And of course, then there's cerebral imaging, for example, through an MRI and CT scans to look at the structure of the brain. But they also can be used to help to rule out brain tumors or blood clots in the brain as the reasons for the symptoms, for example. So treatment and management, I'm not really going to go through this in any detail at all, but I think one of the key principles to understand is if there's an acetylcholine loss, then we want to have more acetylcholine available to our postsynaptic neurons. And so therefore the aim is to increase the levels of acetylcholine in the synapse and thus enhance postsynaptic neuron function. And acetylcholinesterase inhibitors increase acetylcholine levels in the synapse. So, that's a theoretical way to try and preserve some neuronal function, I guess, postsynaptic neuronal function. So really the key is you can't prevent Alzheimer's, but you can keep your brain sharp. Get those crosswords going, get the Sudoku going and keep on reading. And you can try and keep healthy. Do your physical activity and have a healthy diet. So finally, last little set of questions for you. So what I'd like you to do is just press pause, have a little bit of a read, and then we'll go through them. True, they are basically a series of true or falses as always. Okay, questions. Which of the following are correct regarding Alzheimer's disease? Build-up of beta-amyloid plaques inside neurons leads to altered neuron-to-neuron communication and ultimately neuronal cell death. That's obviously incorrect. The beta-amyloid forms outside the cells and affects the synapses and therefore communication through that route. Beta-amyloid plaque and neurofibrillary tangle formation form in areas of the brain important in memory and learning. That's obviously correct, for example, in the hippocampus. Acetylcholine levels are significantly reduced in Alzheimer's. That is correct. Therefore, there's poor communications between neurons and potentially cell death. Acetylcholine plays an important role in cognition and understanding. Yes, that's obviously correct. And cortical hypertrophy is a major neurobiological change observed in Alzheimer's. Obviously incorrect. It's not hypertrophy, it's atrophy, it's death. So neuroinflammation obviously is another major neurobiological change. So remember, this is just a really crude overview to the topic, and you will get far more in-depth and complex sessions to follow.